Good day everyone. Welcome to this session on genotype-guided therapy in cancer and infectious diseases. I'm Dr. Nora, and today we'll explore how genetic profiling of both tumors and infectious agents has transformed the way we approach treatment. With the advent of precision medicine, we are now able to match therapies to specific molecular alterations, leading to improved patient outcomes and minimized toxicity. We'll begin by understanding the foundational principles of how genotype influences drug response, then move on to real-world clinical examples, and finally, discuss emerging trends and future directions in this rapidly evolving field. So here are some of the key benefits of using genotype-guided therapy. First, it helps us match patients with the most effective treatment. Instead of guessing or using a trial-and-error approach, we can choose drugs that are more likely to work based on a patient's tumor or pathogen profile. Second, it helps us avoid unnecessary side effects, especially from drugs that probably wouldn't help in the first place. And third, it enables targeted therapy. When we know the specific mutation driving a disease, we can go after it directly. That leads to better outcomes overall, more effective treatment, fewer side effects, and ultimately, a more personalized approach to care. Let's look at some real-life examples of targeted therapies used in cancer treatment and infectious diseases.
This table shows some key examples of genotype-guided therapies in both cancer and infectious diseases. You'll see how each drug targets a specific mutation. For example, trastuzumab is only useful if the breast cancer is HER2 positive. Without HER2, it doesn't work and can even cause harm, like increased risk of heart toxicity. Imatinib is another landmark drug. It targets the BCR-ABL fusion gene in CML, and it also works in GIST with c-KIT mutations. This was one of the first major breakthroughs in targeted cancer therapy. Then we have vemurafenib, which only works in melanoma with the BRAF V600E mutation. If BRAF is wild-type, it can actually make things worse. Crizotinib is used for ALK-positive lung cancers. Without ALK rearrangement, it doesn't help. That's why testing is critical. You'll also see examples in infectious diseases like acyclovir, which depends on viral thymidine kinase activity to work, and HAART, where HIV genotyping helps tailor the antiretroviral regimen to avoid resistance. So this table really brings home how genotype-guided therapy is about precision: right drug, right target, right patient. To wrap up, here are the key points I hope you'll remember. First, precision oncology isn't just about the patient's own genetic makeup. It also depends on the mutations present in the tumor itself, and in some cases, even the genetics of infectious pathogens. So, we're really dealing with multiple layers of genetic information. Second, when we integrate genotyping into clinical practice, it helps us make smarter treatment decisions. It means we can choose the right drug more confidently, avoid unnecessary harm, and ultimately improve patient outcomes. That's the real power of genotype-guided therapy. It brings personalization to a whole new level. Here are the references for today's discussion. Thank you.